This will be recorded. So hello everybody, my name's Caroline Locke. I'm going to share my screen now with you and we will have a look at the presentation now. This is Air Liquide's portal training for Part B users. So here we go. So what we're going to do today is look at how we complete a home oxygen order form, also known as a POOF, on a Part B portal. Look at new patient HOOFs and existing patients. So completing the HOOF or home oxygen order form on a Part B portal. So in order to complete a home oxygen order form as a prescription, it is done online. So the Part B portal can be accessed through the website here, www.airliquidehomehealthcare.co.uk/HCP. Once you've signed in there, you need to be a registered clinician within London to be able to prescribe oxygen. And so I'm going to take you through the process of how to become a registered clinician to prescribe oxygen. So what this does is it helps you to select the most suitable equipment from both a clinical and a cost-effective perspective. And it is done quickly and efficiently. I've just lost my presentation. Can you see now? Yeah. So this can help you complete a HOOF order form quickly and efficiently by sending the Part B HOOF online to Air Liquide. It helps you to be able to choose all different types of equipment, including static and ambulatory, and is available for home oxygen assessment and review services, which are adult services, but also for paediatric services and other specialist teams as well. The paediatrics are able to prescribe on a HOOF B portal because your children are never still, they are all over the place and they need to have access to ambulatory equipment. So this training will enable you to complete the Part B HOOF on the Air Liquide portal, and following your registration, once you've registered, it is your CCG home oxygen lead and the portal user manager who will authorise your Part B access, not Air Liquide. We are not the gatekeepers of whether you are allowed access or not. It is down to your trust and also the oxygen lead in London. So part of this criteria is that everyone who completes a Part B training before they get access has to complete this training. You can have either an nhs.net email address or nhs.co.uk to gain access. So here is a selection of different types of equipment that we provide as a home oxygen supplier within London, and the equipment gets updated every so often as according to what is available out there and the needs of the clinicians as well. Can I just say that not all of this equipment is available for paediatric services. So for instance, if I look at this piece of equipment here where my cursor is, and this one, they work by providing what we call pulse or a demand type of a flow setting, which is not suitable for paediatrics. It's only available for adults. And so therefore, when you come to complete your portal, or when you come to complete a HOOF form, if you register as a paediatrician or a paediatric services, this sort of equipment will not be available on the portal for you to pick. So prior to completing a Part B HOOF, this is the Department of Health regulation, you must complete what is known as an initial home oxygen risk mitigation form, or IHORM, and a home oxygen consent form, also known as a HOC. This is an absolute requirement from NHS England. So the information on the IHORM, which is a risk mitigation form, allows clinicians to make a considered risk-based decision before requesting oxygen within the home. The consent form, which goes alongside the mitigation form, is consent that the patient allows Air Liquide to have access to patient identifiable data, the fire rescue services, and also if they've got a concentrator in the home that requires electricity, is electricity rebate. So these forms must be completed and signed. The consent form must be signed by a guardian or a parent, and those instructions on there are read out to the parents so they know what they are signing up for. Okay, so the iWarm form can be downloaded on the website, or for some of you who would know that Paediatric Pan London also has a discharge bundle, which is more pertinent to the needs of children, can be used, so long as a form is used. So once you have acknowledged that you completed these forms, at this present time, you do not send them to us. You keep them in the patient's record, and you need to tick the boxes within the portal to say that you have completed these forms. Later on in the year, these forms, the actual risk assessment will be incorporated onto the portal so that you do not need to complete a form. But until that process is complete, at the moment, you do need to complete the forms. So the Part B portal is a two-way information portal. It has added security levels to allow access to NHS patient data. So therefore, when you sign in for the very first time using a type of device like a PC or mobile or tablet, you must put in a 6-digit security number. That is sent to you via your nhs.net or your co.uk email address, and then you can enter the information. It's a little bit like, I guess, Amazon or PayPal or Facebook, where you have to have that extra security. Okay. And the Part B portal is designed for you to access information about your patient. You can select the most suitable equipment, submit a new hoof, view a current hoof, and also review reports and invoices. So to register as a new user, and I will take you to the live site later on, you go to www.airliquidhomehealth.co.uk /HCP, and then you register as a new user and you complete all the fields. Everyone will have a profile based on their CCG. So those who are in the new CCG, such as North Central London, your profile will be based in North Central London. You will select paediatrics if you just see paediatric patients, clinical codes, GP practices as well. So GP practices is based on where the patient is registered with a GP, is where the billing goes to that particular practice. So depending on your access rights, you'll be able to create a new hoof, view existing patients, and summarize invoices and reports. And I'll show you how to go through those processes now. So email address can be NHS or co.uk. You select your role, which would be a Part B specialist. Administrators can have access to the Part B, but they will not be able to prescribe. So some teams will have administration staff or non-clinical staff who will be able to help manage the services, so they can actually help patients go into clinics, etc., etc. This is more, I would say, pertinent to adult services. Your region will be London, not the Southwest region, which is like Cornwall and Devon area. Your CCG will be based on where you are, your job description, you can enter that as well, and your services. Enter your address of your services in this section, and then select the most appropriate patient group you see. So pediatrics, which will get rid of all the equipment that is not available to you. If you select both, you will see both types of equipment, which I would think is quite confusing for those who only work in pediatric services. So the next bit is really important, patient identifiable data. Now, by ticking this box, you will be able to see patients' names and addresses when you want to review patients that you have seen. So I suggest you do tick this box. It also makes it easier for you to see patients, because if you don't tick this box, you need 3 separate bits of information about the patient to access any patient summary details. If you are working in a services where you want to look at invoices, then you can tick this box. And then having access to the reports allows you to see on a day-to-day or, sorry, what did I do there? Or a monthly basis. Let me just go back there. What happened there? Yeah. What your patients get up to, whether they're actually using oxygen or whether they're actually ordering oxygen, ordering too much, or perhaps in some instances where I've come across in the past, whereby they don't use it at all. Okay, so you will then automatically assigned to see the data for all clinical codes. So I would suggest, again, clicking all clinical codes rather than being selective. You can deselect them if you want to. That is entirely up to you if you work in a particular service. If you wanted to look at a particular region, so if you work in, say, for instance, North Central London, and you're only interested in data that is in Barnet, for instance, what you can do is deselect all GPs, which that deselects the whole of North Central, and a box will appear on this side whereby, with our support, if you ring us at the time, we can select all the GPs in Barnet, and that will give you access only to that particular area. So if you want to do that, please let me know. But in the meantime, you will see the whole of the data for the whole of that particular CCG. Then you need to create your password, and this needs to be at least 6 characters long, 1 uppercase, at least 1 digit, and 1 non-letter or digit character as well. So all I suggest here is, if you don't type in exactly what it says in the first box, in the second box, it kind of deselects some of the information you've already done previously, and you have to start from the beginning again. So just be careful about this particular bit. Okay. And then you register. Once you've registered, we will send this information to your portal user manager and this will be managed. And what they will do is to ensure that you have the authorization to be able to do a Part B portal. All right. This can take a little while. It may take up to 1 or 2 weeks. And if you don't hear back, please let me know, and I will hasten them by emailing them and seeing what the hold up is. Sometimes it's because CCG hasn't responded. Other times it may be due to sort of like in the summer months because someone's on holiday or their workload has increased. So once you've got confirmation, this will be sent to your inbox, your email inbox, and this is when you can set up your 2-factor authentication. Whoopsie, we log in using your email and your password that you use to register. And on the following page, you'll be asked to enter a 2-factor authentication code. Now, from the drop-down menu, you can either select email code or you can receive that via an app. So most people do prefer to use an email code. I'm not going to go into the intricacies of having an app at this stage today. If you prefer that because you're mobile, you're in the community and you're doing the hoof, on the hoof, shall I say, then you can have, if you have a smartphone, you can download an app that will provide you that code that you can use to enter to get into the portal. So I'm going to skip that little bit there. And that's the QR code that I will send to you if you prefer to have an app to get your 6-digit authentication. So ongoing secure access. So next time you signed in, you'll get that and you then enter that and you'll be into the portal. So once you're in, you can then send a new hoof. So before you start, you need this information at hand so that you can complete the online Part B hoof. So you need an NHS number for the patient, the full name and contact details, the delivery address, GP practice, litres per minute, hours per day, equipment type and quantity, and the consumables that you require as well, whether it's nasal cannula or mask. Complete all sections of the hoof. The hours a day in all modalities cannot exceed 24 hours, and the litres per minute cannot exceed 15. The mask selection will depend on the flow rate that you select. Okay. I will give you a bit of a live demonstration later on so you can see all the intricacies of ordering home oxygen. So to begin the process, you click Submit a Hoof B online. And the first thing that pops up is whether you have completed the risk mitigation and the consent form. So at this moment in time, you just tick the boxes. And the third box here is to declare that you're a registered healthcare professional who is responsible for providing the information, and it is completed as true as possible and correct as well. And know if you provide any false information, because this is from the Department of Health, this is not Air Liquide saying this, that you can be liable for prosecution and civil proceedings as well. So it is your responsibility not to share your email and password for the portal with anybody else. This should never be completed by a non-clinician, and you are responsible for the hoof. Okay, for the order form. So on the left-hand side here, you can see a progress bar, and the progress bar tells you at what stage you are at the completion of the hoof form. So once you've completed those forms and you've tucked them away in the patient's notes, you just need to tick the boxes and then you proceed forward to next. This page here is where the patient requirements are, is probably the most important page for the whole form. So if you know that this patient has got oxygen as an existing patient, you can tick this box, which helps us to know that there's information out there about the patient already. Okay. Now, this, if you have selected as pediatrics will only pop up. Please use the clinical code. There are 23 codes to select from. Can you please consider which code best suits the patient's diagnosis, because we do get lots of codes which patients who are wrongly coded. This information we do send to the Department of Health, who then are able to audit and monitor what type of patients are on oxygen. Now, one of the discussions I've had with operational leads is we do not have a code for RSV. And so therefore, what we're asking, or what we're saying, is perhaps we put that down as other, for the purposes of RSV, but we would need you to enter in additional information that this is RSV. This will help us with auditing, which is what we did with COVID, and it will always help us with the removal process of oxygen once that child has completed using their oxygen. Now, we cannot remove that oxygen ourselves, but we can prompt the clinician by going through a search to see that patients are RSV, and it just helps us to make the data more easily accessible. Okay, so this first box here, maximum static flow rate and hours per day, is for any equipment within the home that they're going to use at home. So this is whereby the child is mostly in that particular household. So this is where maybe the hours per day is the most that they have. With ambulatory oxygen, it's when they go out occasionally, okay? When they're out and about, maybe mum's going to do a school run to pick up their children or going shopping. So ambulatory oxygen should only be used in those instances, okay? Occasional use. So the maximum static flow rate, if you're using what we call a variable flow rate between, say, 1 and 3, for instance, you need to enter in this box the maximum flow rate you want that child to have. By not stating that and then saying to parents at a later date, you need to increase that oxygen, they may not have the correct equipment to be able to do that. So by stating the maximum flow rate, it makes us understand what your requirements are, and we'll give you the equipment, or give you the selection of equipment that you're able to choose with those variable flow rates. Okay, so the maximum static flow rate is entered there, and then the hours per day. Again, in the ambulatory section, the maximum ambulatory flow rate and hours per day. If you if you require tracheostomy or NIV CPAP, you can tick tracheostomy and we can provide a straightforward tracheostomy mask. If you require NIV, or there is NIV or CPAP for that particular child, we do not have the contract, Air Liquide does not have the contract for those services, and therefore we will not, as a company, be able to connect the oxygen to the equipment for ventilation. So it is important that you understand that mum, dad, parents, guardians have to be trained in connecting the equipment to their external equipment. And we can also not guarantee that it's going to work, okay? If we connect it, it may be that, and then we connect it to the, or our technician connects it to the wrong porthole, and we would be liable if we get it wrong. So it's important that either you are present for that or the parents are understanding where it goes to. So if this flow rate for any of this equipment is variable, you need to tick yes. And then we move on to the next page. So in this instance, this is just a screenshot we've done here. This is a static prescription for a static concentrator. And what we do is we provide the backup cylinder in the event of the machine breaking down or there's a power cut in that particular region. So this is a very typical, I would say, a COPD kind of flow rate, whereas 2 litres per minute, which is the maximum flow rate. The hours per day is 15 hours per day. They just want one concentrator and they've chosen nasal cannula. Now, if you are choosing static equipment, say for instance, for a child, you need to know you need to know what is the lifestyle, or any equipment to be fair, the lifestyle of the parent and the child. So are they going, how many hours a day they're going out? Is it every single day they're going out and spending that amount of time out the house? How far is the bedroom? Do they just want one static cylinder, or do they need one upstairs in the bedroom? Do we need one downstairs? And so forth and so forth. Are there any other children in the household? Would there be any tampering of the equipment? Is there a risk of people tripping over the equipment? And so forth and so forth. So the more you gain in the information about the environment in the house will help you to give you the ability to understand the type of equipment, the risk that's imposed as well for having that kind of equipment in the house. So for a variable flow rate, you do need to enter the minimum flow rate so that we understand what the variables are. Now, if this flow rate was much greater, say for instance, the maximum flow rate was 15 litres and the minimum flow rate was 0.1, and you're using 15 really for emergency kind of a treatment, we need to know what exactly you want us to set the equipment at when we deliver and install the equipment. It's very difficult for the technicians to hazard a guess, and I would say parents should have a plan and been trained to understand what are the variables in the event of different scenarios. So it's really imperative that there is an understanding from the parents' perspective, and their responsibility is passed on to the parents to understand that as well. Okay. So there is a choice for humidification, but we do follow BTS guidelines, which says that if you want oxygen humidified, then there's a minimum set flow rate of 4 litres per minute, because under that flow rate, there is the danger of the water accumulating in the tubing and occluding the oxygen flow. So if you decide you want humidification, you do have to understand that there are some risks with that as well. So there is a drop-down menu here, which is like a plus sign. It's a minus at the moment, which actually then provides you the sort of charges that is for this type of equipment in London and how often refills would be. And it just gives you an overall sort of costing of what this kind of equipment would cost your CCG, so long as the patient uses it compliantly. If they don't use it compliantly, then the charges would be either greater or lesser. Please remember, oxygen is a drug, okay? And it should be used accordingly. So once you've done those, you've entered all the information, you've got the information, you've selected your equipment, we move on to the patient and carer details. So this is the information I'd ask you to have available at the beginning so you can complete this smoothly. And we ask you here if there's any additional information that you may feel that you may require for us to know about this job and any other future job that we can pass on to the technician. So this isn't a mandatory field, but what we say is it could be there's instructions for using a static cylinder in addition to the backup during an emergency, so clinical emergency. So if you decided that you wanted a concentrator, which we provide a backup cylinder, but in the event of the child becoming apneic or something different from the clinical scenario, and it's going to use people for emergency, then this is where you provide that information as well. Or it may be something to do with the backup flow as well. Or this is, I would suggest, is where you enter your RSV code so that we know that this is an RSV clinical code for this particular child. Okay. You can, if you wanted to, with the permission of the patient, enter their email address, and we can then share correspondence and newsletter. This is not compulsory, this is an optional area, so long as you have permission from the patient. So what we need next, as you can see now in the progress bar, we've moved down to patient GP details, is for you to enter the practice postcode. Now, as soon as you start, as soon as you start typing, it will start populating this particular page automatically, because we do have all the codes, practice codes, postcodes in the UK. So that makes it quite easy for you. So once you've completed that and it's populated, you just press the next button down here to move on to the next page. Now, additional supply, this could be that parents don't live together, or you want exactly the same equipment in grandma's house because the child spends a lot of time at grandma's house, or it may be that the child goes to school and requires that exact equipment at school. Now, this may not be the case. You may need lesser or more equipment in a different property. If that is the case, then you need to complete a new hoof with the address of that particular address to create a different type of hoof. This is just for like equipment that you want in a different property. All right. There is an option to put in the start date and discharge and the end date so that we can remove the equipment. Every time we create a new account, we give the patient what we call a P number. So that further anonymizes the patient's data, because it's easy to trace an NHS number, where it's less easy if you have what we call a P number. As a third-party supplier, contractually, we provide what we call P numbers. So for each account, even the child had 2 or 3 accounts, they will have a different P number because it will be a different address, which is allotted to them. Okay. So you don't have to have this additional supply, so you just tick no. If this is a temporary holiday supply, so say for instance, if the child was going on holiday down to Cornwall this summer, and they've already got an account at home, but they want a different account, you can use this as a temporary holiday supply. This is a new hoof for a holiday supply. So domestic, holiday or secondary accounts will, as I said earlier on, will have, if they have the same equipment, a same home address, same UK, then they don't need to have your permission. They just have to create that account with us. If it's different equipment, then they need your permission to ask for different equipment. So we're moving on now to technician safety. So it's the utmost important that we may manage and mitigate any risk for our technicians when they visit a property. We have had incidences where our technicians have been assaulted. So this is a mandatory question. So if you have any knowledge of any risk within the home, please let us know and provide us with the information and details. And for an example, this could be dogs, which are not very pleasant, or the patient or family member is prone to angry outbursts. In this example, you know, we would send 2 technicians as a safety measure to the property, and whereby we can actually manage those risks. where the risks become unmanageable, we have the right to refuse to provide a service that I have not had that happen in London in the time I've been there, but where we have done so is we've actually had to get a police escort in the past to go with technicians to a property where there has been a lot of violence. So please let us know if there's anything that you know that's untoward within the property. Now, this also goes for, say, for instance, if you know the patient has got COVID in the property or there's an MRSA risk, we need to know whether we need to gown up PPE. In the case of our RSV, do we need to protect our technicians to wear a mask so that they don't pass it on to their families? So these are the sort of things that we need to know. Okay, it's not just about violence or nasty dogs. Right, so if you're a hospital discharge, you press yes. If it's no, then you move forward. And again, you just need to give us the information required for hospital discharge and the contact details as well, so that if there is anything untoward about the installation, we can actually contact the hospital and speak to someone. Okay. We're nearly getting there now. So this is about delivery details. So we either have a standard 3-day business delivery type, which is 3 business days. It can be a next calendar day. This is if you put the hoof in, you pop the hoof in before 5 p.m. If it's after 5 o'clock, it will be treated the following day. And then there's the urgent 4-hourly delivery details as well. So with a 4-hourly delivery, we have a KPI that basically means that we have to be there within 4 hours, which means that our technician, they could be doing daily rounds, they have to drop everything and run to that 4-hourly urgent call out. This does have additional charges with it because it is a superior service. The thing I would say is that if it's within 4 hours, it could be within an hour or half an hour, it depending on the location of the technician at the time of him receiving that urgent call out. So if it's within half an hour and they get to the household and nobody is at home, then it is classified as a failed delivery, and it's likely that we will not be able to go back to that property until the following day. So it's really important that you confirm that someone is going to be present at the address to receive the equipment, but not only that, they also receive the training. And this is a very important factor in the fact that it is best to give the training to the person who's got the best interest in the child. We have had incidences in the past whereby a neighbour or even a grandma or an aunt may have received the pet training, and it's a little bit like Chinese whispers. The information that's passed on may be slightly different, or they may not remember the whole of the training and give different information or omit information about what is about safety or about the equipment. We do leave brochures, information brochures with you when we do an installation. If you do have any queries or the patient has any queries, we do follow it up with a phone call 2 weeks after the installation. But if there's any concerns, the patient has any concerns, we do have a customer service helpline where they can help answer some of the basic general concerns. If there's anything clinical, it is then passed on to the healthcare professional who has written the hoof. And if there's any discussions around that you're not sure about, then you can always discuss it with me as well. Okay. So you can also use this button here, which is admin only, for updating information in a hoof that does not require a technician to visit. It could be something like a change in the patient's or the clinician's telephone number. If you require the flow rates or the hours per day to change, for instance, that requires you to do a new hoof. Okay. Not sure if there's any questions at this point. If not, then I will proceed. So the next part is the very last bit, which is the declaration. This will be where you have entered in your profile. This will be populated for you. Okay, so before you send off your hoof, submit your hoof, you can press this button to review your hoof to make sure that you feel happy that you have entered all the correct information within the hoof. You can either do that or go back to here, patient requirements, and make sure that your hoof is what you want and it's what's your requirements. Now, you can then submit the hoof. Now, before I go for the next bit, I just want to say that it is your responsibility to ensure that the information you provide in your profile is always up to date. So if your mobile telephone numbers change or your contact details change, it is your responsibility to ensure that you update this. If you don't, or you move to a different trust, say for instance, because you've moved jobs or you've updated your mobile telephone number, if we need to get hold of you because there's a query on the hoof and we're unable to contact you, it can cause delays in the hoof being installed, or the equipment being installed, or if in the event that we cannot get hold of you, that hoof will be rejected. Okay, and we will send you an email to say the reason why it's been rejected. Okay. So when you press submit, a copy of a hoof is automatically sent to us and your email address. So you can click here on the next page and you can view your hoof and download it as well. Save it to file, copy it, print it, whatever you like to do. Or your records. So with a hoof confirmation, you will receive a confirmation to your email address within 1 working day if it's a standard hoof. If it's an urgent or a next day, it will be sent within an hour of receiving your hoof. It is really important that you check the confirmation and ensure that the information has been transposed correctly. If you don't get that confirmation within the appropriate time frame, then please contact us either on the phone number here or the email address. So I'll leave you a minute to copy that down. Okay. So existing patients. You can search for existing patients by going to patient search. So if you tick PID when you registered, you only need one piece of information to search your patient. If you haven't, then you have to provide us with 3 different bits of information to actually search a patient. And once you search a patient, you find the patient that are listed, and then what you can see is a summary of the patient's details. And so you can see the patient's information details, their clinical code, etc., what type of hoof it is. This is the patient's prescription, any activity within the last 5 visits that we've done. You can see when they're due their next field risk assessment, which is carried out by Air Liquide. If there's any evidence of smoking, any planned visits, whether they've got a working smoke detector, if they're in PEP, what we call PEP. PEP is whereby patients do not allow us into the property to do a field risk assessment, and if that does happen after 6 months, they go into what we call a PEP process. So one of the things I ask you to do is when you get the patient to sign the consent form is to read to them that what their responsibilities and what it entails. And one of the things is to allow reasonable access into the home so that we can carry out these safety measures. And it's not just for us, but it's also for them, and to ensure that the equipment is working properly as well. Okay, if you look down here, this is what we call the concordance data. So you can see within this particular instance, this particular patient, they've got a static equipment which is for 22 hours per day. Their actual usage is 0.9, which is a variance of 21 hours. Therefore, they're underusing it by 95%, almost 96%. So therefore, in this particular instance, the patient's not using their equipment, and you would be asking questions as to why that is. So it may be that it's because they have patients got better, they don't require the equipment at all, and it hasn't been updated with us, they haven't been removed, or it may be that patient has a misunderstanding and needs education for various reasons. I don't know, but it's something that you may want to question. And I would suggest that, you use this not as a tool to blame, but as a tool to try and understand the patient's perspective. Okay. So you can also, down here, resubmit a HOOF in the patient search bit to update the HOOF if necessary. We also take the meter readings, which helps you understand if they're using the concentrator as well. You can also use this part of the form or the portal to remove equipment as well. So if you remove equipment, you can give us an idea as why you're removing the equipment. Is it because it's no longer required, the patient has passed away, or is it due to safety reasons such as smoking or dangerous use of maybe open fires or candles, etc., and that you feel that the oxygen is no longer safe in this particular property? It asks you, have you spoken to the patient? Has the patient agreed? And just to let us know what the removal address, because sometimes patients do remove their equipment to a different address as well. So if you've got any problems, accessing problems, then contact us on the Air Liquide patient support. If you've got any questions, you can ask us on patient support. Removal access, again, on the patient support. If you've got any additional access rights you want, so for instance, if you didn't tick PID in the beginning, you want it now, you can go into your profile and tick that, or actually contact your user manager to say, this is what I want. If you've got any queries about equipment or clinical advice that you require, then that's myself. And if you've got any feedback, again, that's to me. So thank you for your attention. What I'm going to do now, I'm going to spend the next 5 minutes going through the portal with you to show you. I hope you can you see on my screen, everyone? To show you the actual Air Liquide portal. So this is the front page of the portal. This is where you enter your email address once you've been registered, and your password. This is where you register. This is Part A, and this is only for Part A prescribers such as GPs and those who are not registered in Part B. Once you become a Part B prescriber, please do not use a Part A to send a prescription. Now I'm going to enter my password. To enter, I log in and it takes me to a different page. So this is where you submit a new HOOF. This is where you can download your risk assessment and your consent form. This is where you can view patient guides and literature. If you signed up for reports, this is where you can view reports. Down here, if you want to search a patient, you can just, if you've got PID, you just enter one piece of information, and then you can actually resubmit your HOOF, remove equipment, through there, through Part B. So I'm going to enter Part B now, and it takes me to this. This is my progress bar here. This is where I say I've completed all my forms. I declare I'm healthcare registered health professional. And then I go to this box. So pediatric services, there are 23 clinical codes. So just scroll up and down to see all the different types of codes. And then here we enter the flow rates. So it starts from the least, which is 0.01. All I say is just be careful and double check what you've chosen. There's 0.01, there's 0.1, and it goes right up to 15. Okay. So I'm just going to put here, say for instance 3. I can just type it in. The hours per day, and this should be the most hours per day. I'm just going to put 15 in there. Again, I'm going to check 3. I'm just making this up, by the way. And then actually for the ambulatory, This is worked on a weekly basis. So if you said 4 hours per day, we will then supply you with oxygen, 3 litres per minute for 4 hours a day, every single day for 7 days a week. So if the child is only going out, say, for 1 hour a day, or only goes out at the weekend, by putting 4 hours down, that's 4 times 7. Okay, so if you want to limit it to, say, just 7 hours, then I would suggest you put in 1 in here. And that will also reduce the number of cylinders that's in the household. So just to be sure, just to make you aware, the maximum number of cylinders, see, I didn't put a clinical code in there, so it stopped me moving forward. I'm just going to put here, I'm just going to put, well, I'm going to put other condition. The maximum number of cylinders in a household is 8 in its totality, okay? Unless there is twins and triplets in the house, and that makes it a little bit more complicated. But the Department of Health guidelines is 8 cylinders. So if you're using a static cylinder, it's got a backup cylinder, it's 8 minus 1. We're not saying you should put 8 cylinders in. You should keep it to a minimum if possible. So for instance, here in ambulatory cylinders, at 3 hours a day, it says I need a quantity of 3. Well, actually, the child only goes out once a week. I'm going to reduce it down to 2, okay? And my minimum flow rate is going to be 1. I'll put 1, and I'm choosing that piece of equipment. And I need a nasal cannula for that. Now I'm going back to my static flow rate. Actually, this is a child, and actually it's only 0.5. I can be flexible here, and the flow rate goes up to, sorry, let's put 1 here, 1. And I'm being flexible and saying this is 0.5. This ensures that you get the right kind of equipment. And actually it's 15. Yeah, I might need 3, and then it's yes. And then I need to tick that box. Now, if I miss anything out, it makes me go back. Just checking it over. I think that's all right. And then I just proceed to the next bit. Okay. But if I want to go back and check, I can go back to this page and check. Or I can make alterations here and go, actually it's only 1 I need, and the minimum is actually 0.5. I can play around with this as much as possible.
Sorry, Caroline, just to check, so the hours are worked based on what's needed weekly?
Yeah. Okay. So it's on a weekly, it's an algorithm. This is the whole thing is on an algorithm. So when you enter the flow rate and the hours per day, we will then in the background calculate what is required, and that will give you the quantity over a week, right?
Okay,
so
great.
If I kind of like go to this, what am I? Let's move on. Let's move on a little bit here. Mess it up a little bit, but anyway. So if I look at this particular one here, 1 to 0.5, I'm just reducing it a bit. If I press this plus button down, it's saying here at 1 litre per minute, and actually, do I actually consider a static cylinder then, rather than a concentrator, rather than a static cylinder, because that's quite a high flow rate, because then it is, if this child's got steady, stable lungs, and there's no variation in their clinical needs, and their ongoing complex care is going to be on oxygen for a long time, then I would say you should be using a concentrator rather than a cylinder. Now, in the event of a child having very low flow rate, say 0.1, 0.2, the difference between that and a concentrator, we do have concentrators that do supply 0.1 and 0.2, is there's more likelihood of another child tampering with it. There's a likelihood that because it's a medical device, with all medical devices, there's always a standard deviation, and that could be anything between 5 to 10%. So if you want accuracy, then, and you've got a low flow, I would say for clinical safety reasons, you should be using a static cylinder. But once you start hitting 0.5 or above, then, and the child's going to be ongoing complex care, you should be moving over to concentrator, because the supply of something like a static cylinder, which is very high, say for instance 15, you're going to require 8 of those, and there's always a likelihood that if they run out, they're not going to have any oxygen. And there's more likelihood that costs go up. You can see, look at the cost of that compared to, say, something like that. But it's a safety issue as well. Okay, so this actually tells you how many refills is required for that prescription as opposed to that one. Look at that, 6 times every single day. So we base our services on the rental of the equipment, but also on how many times we visit that particular property. So it's based on the technician's time. I'm going to stop sharing now. It's based on the technician's time that they have to spend going to that property, as well as the rental equipment. So the more they visit that household, the more expensive it becomes. So it's about managing that account. Now, we do have parents are quite chaotic and maybe need some help and education about how to manage their accounts. So the costings go up and up. So this is where we do clinical escalations and inform you that there's an issue with this particular account. Maybe it's just before a child becomes unwell and this mum starts using the oxygen. But if there's no clinical plan there, which you guys provide, to say you should contact services, the child deteriorates, you notice signs and symptoms, then actually rather than increasing oxygen, because there's also danger of it giving them too much oxygen, there should be a plan that they contact the services or contact the hospital or whatever. So it is not acceptable to say you just increase your oxygen if the oxygen has got a prescribed rate, unless it's got the prescribed variable rate written as part of the HOOF. Now, we tend to go to properties sometimes, not just paediatrics, but adult services as well, whereby patients are nilly-willy using oxygen, and some of those patients can be hypercapnic and they're causing problems themselves, and they end up doing the revolving door syndrome in A&E. So if your prescription changes, it is vitally important that you update the HOOF. Okay, if you don't, and one of our technicians goes and visits the property and notices parents are using oxygen outside those remits, it causes kind of a friction between the technician and the parents, who then may not want the technician to see what's going on, but also the prescription is not up to date. Yeah. So we often get, and also there could be a clinical risk. So I've had an incident whereby a child was using emergency oxygen on a static cylinder, which was 15 litres per minute on a non-rebreathe mask. So we all know with a non-rebreathe mask, you've got to inflate the actual bag to ensure that there is oxygen in the bag, be able to use the bag at a certain flow rate between 12 and 15 litres per minute. Now, this particular child went and saw the tertiary centre, and tertiary centre said, well, actually, you don't need to use 15 litres per minute. The child was in a school, so this was a school account, and you just need to use 2 litres per minute. Now, that information got transposed to the services and the nursing team in the school, but because the prescription was not updated, when the school put it onto 2 litres a minute, there was no way that bag was going to inflate and that child was suffocating. So you can see the dangers of not updating the prescription. So it's really important that you drum into your tertiary centres, in your hospitals and the community teams, that if there are any changes to prescription, it has to be updated. Okay. So I'm going to take any questions now, because I believe Tendai is going to come onto this call very shortly. If she's not already here, I'm not sure if she's here. Tendai, show your face. Thank you.
I'm here.
Thank you, Tendai. So I'm going to hand over to Tendai now, who is the chairman of Paediatric Pan London Oxygen Group. Some of you may have seen Tendai earlier in the call that we had with the North Thames Paediatric Network Group. Some of you weren't on that call, but thank you, Tendai, for taking over as the chair of PLOG. Thank you.
Yeah, good afternoon, everyone. I'm hopefully not going to take too much of your time, because I know that there's a few things maybe you want to go through with Caroline regarding your portal training. I think the whole reason for me joining was just to have that RSV discussion, because we know that's a hot topic right now everywhere. In all my years I've dealt with RSV, this is the first time I've seen it having so much, audience. We've been championing RSV for a long time and nobody really was bothered about it. So it tells you how RSV surge can change everything around. So I think the whole reason is just asking probably the people that are already on the call. We've joined a few forums in the past couple of weeks, just asking a few questions about how ready are you? And we've created a mini survey with Caroline. We hope to call it mini, but it's just a few questions so that it starts prompting people to ask them, how prepared are they and what are the plans that you're putting within your organization or within your trust regarding your RSV surge? And also part of it as well is about empowering you as clinicians so that at the end of the day, you're not going to just accept that this is how we're going to do it because this is what we can do, but also safeguard yourself, safeguard you as a registered clinician, that you also do things in the right way, in the safe way. And I think part of it is just asking that, have you put guidance in place? What guidance are you putting? Because I know because of the surge, we're just putting some guidance is just about bronchiolitis, which is fair enough, is to manage, those children. But in particularly regarding RSV, surge, how are we managing that? What's the saturation level we are saying? And where's the evidence in that? Because already we're hearing so much variation of saturation levels that are going to be acceptable. Where is actually the evidence coming from that people are accepting this type of saturation? How confident are we to start sending babies home that have never had oxygen before, that parents walk into A&E and being told that we're ordering oxygen within 4 hours? You've not done competence with them, we've not done anything, and then expect them that actually you sort it out when you get home. Somebody will come to you in 24, 48 hours, depending on their calendar or their availability. You start asking all those risk factors that are being put in place in how we are rushing to do things. We need to make sure we're definitely putting plans in place to safeguard our children, and we need them to be at home as much as possible. But actually, we need to do it safely. And I think that's the whole reason. So I think I'll open it up just to see if there's anything that you can highlight, and we will circulate a mini survey that will help us to do some scoping. And I think the whole reason from PLOG point of view, we are already working with the NHS London, Moni does commissioning, and we're working as well with the Oxygen Task Force, which is the adult group, and they've done already service specification for adults, especially during COVID. They had to do some alterations. So now what we're doing as PLOG is scoping what's happening so that we can put a service specification also that is specific to support your teams, your organizations, as you do your preparation or as you start getting those patients into your books. So I'll open up if there's public people have maybe a question. I might not be able to answer everything, but I will be able to signpost if things that I am not sure about. So anyone, maybe you've already got a plan or you're thinking about it, or you as a clinician, what is it that you think you need to equip yourself? What is it you think? Because then we can put that in the service specification to say, actually, this is what we think the clinician that is going to support or lead this service will need to have this and this and this, the skills, the knowledge in place. So please feel free. I imagine silence is a good thing.
Tendai, can I ask a question? How do you feel the RSV surge is going to impact on community services? We have had discussion in the past about hospital at home teams preparing themselves because they have integrated services. But how is this going to affect resources? Things like staff, and also like things like saturation monitoring. Do you feel this is feasible within the community services without the resources or skills, and how's that going to work?
I think we already know that the workforce that we have are already stretched on the ground. The people are working above and beyond on their job description. So I think, and when we did a bit of scoping about the hospital at home, not many areas have that. I think in London, is it about 6, 7
Five hospital home services across London is what I gather.
So we know that there's community pediatric or children's teams, there is community neonatal teams. So I think whatever way RSV surge is going to affect teams or organization, my question, I think, goes back again to everybody is, how are we collaborating with each other? How are we sharing information? How transparent are we with each other about what we are anticipating? Because if we start only working in isolation, that we, the pediatric team, are doing it like this and this is how it's going to work, and that's where confusion starts. The community neonatal teams are doing their own way. The clinicians are doing everybody, physio specialists in oxygen are doing their own. So I think it's about getting those organizations to actually say, are you collaborating? Are you making those discussions as a multidisciplinary approach? And where is the patient in this? How are you making sure that their journey from the moment they come in and they're worried about RSV, or you suspect they got RSV, you do the test in any or the the short stay ward, or the and wherever it is that they come through, depending on your setting, they're able to know that it wasn't hours or days that nobody was talking to each other. And that's what happens with most of the things when we talk to parents, is they always say nobody seemed to know what they were doing. So I think that to us, that's key, is how do we know those pathways are safe and that the parents have a voice, or the carer have a voice throughout those pathways as we anticipate that.
So from my...
Oh, you froze, Caroline. I got Adama.
Hi, my name's Adama. Yeah, I work in Islington, and
Sorry, I lost you there. So what I understand is, when I spoke to someone yesterday, was that some of the paediatric services resources got deployed to adult services to support the COVID. How's that going to work? We think there may be a third wave, fourth wave of COVID and paediatric services, and we know that we're at winter crisis point now in hospitals at the moment, and we know that the RSV surge is going to be fourfold. So I just wondered, I'm going to put that out there to everyone else out there. How prepared are you, and what have you got implemented in your own services in your own areas? I think man his hand.
Yeah, there was already a hand, and Adam had already started chatting when you froze. So I'll let it come back.
It's all right. No, it's fine. The choice of things. So yeah, I'm Adama. I work in Islington. I manage the CCN service, and hospital at home service. So what we decided to do in North Central London is myself and the matron in Haringey, the matron in Camden, we've come together to look at how we're going to be unified in how we address the surge, because we have different services across Haringey, Camden and Islington and Barnet. So we thought we wanted to work jointly, and we really wanted to be sure to work safely, and we thought, we are better in a bigger number in terms of being able to, because the acute have a lot of, obviously, their demands, what their expectations are, and sometimes the acute side we can miss kind of the practicalities of community life, and now we can facilitate a service. So we've come together to formulate we've all got our individual pathways, so we've kind of looked at them, and then we're trying to bring it together, because realistically, we've got a hospital at home service, but they're not going to be able to facilitate a hospital at home service in short notice. However, we have also got issues with staffing, so it will end up that we will end up working like a regular CCN service anyway in certain aspects. So we rather cater for that kind of capacity rather than looking to have the same kind of demand and numbers of what we'd have as a typical hospital at home service. That way we can uniform the way we deliver a service across the boroughs, because Whittington and North Mid and Royal Free and UCLH will get a mixture of different people that cater to our services. So one thing that's is not very helpful is what a person in bed 1 and a person in bed 2 being offered a better service because they live in a different area. And at this point, you know, if we can kind of uniform that service for a bit, then that would be helpful. So that's how we're kind of looking at it. Not everything's finalised yet, but once it is, we are going to, I was going to share that with you, Caroline.
I was going to thank you. That's really helpful. And I was going to say, how do you think PLOG as a group, and how do you think I, working as a respiratory nurse advisor within the oxygen services, help you? I have put some questions in the survey for consideration, and I also emailed Sam Rostron today. Also, what I understand is your North Central London's lead, and she's also got a hold on PQ across the whole of London as well. So these questions have been sent to her as well. So if we can actually support you as well in a PLOG capacity, is there any documentation that you feel that we need to put together? Somebody said to me yesterday that maybe a leaflet or something to have an understanding about the equipment, or we got some YouTube videos which helps the clinicians as well, and it could be, you know, a step-by-step guide for equipment, or maybe it's about more policies and strategic stuff, which PLOG and the Oxygen Operational Lead can help as well. So we're here, I think, I want to say, as a support for the, you know, London and wider, to ensure that our children are safe and they're looked after well.
Yeah, I think that's highlighted and summarized most of the things that I wanted to say. But I think one of the things I really, really want to highlight is that if the children that you possibly might be coming into your A&E or your children's ward with possible RSV or confirmed RSV, and you think these are the risk, please make sure, if they are at that age that they need to have the RSV vaccination, start liaising with your RSV teams that do the vaccinations. Don't leave it until late, because it will make, even if it's a 30 or 50% difference, that would make, we know that we've been advocating with COVID vaccination, how even if it's just that cover of 70%, let's just make that difference. And I think one of the things that we're learning now, especially with social media and, you know, having the internet, parents have more knowledge. Parents are more knowledgeable than we think. They probably know about this. They're probably reading about this, and they probably know that their child might be qualified to have an RSV vaccination, and you didn't mention it. And the worst thing you can have is a child really being poorly, and we know RSV can unfortunately lead to poor, you know, outcomes. And I've seen that in my experience. I've had to sit in child death, you know, overview panels because, you know, children have missed having that RSV vaccination. And it would be sad to be having that if they want to take a legal action on that because they missed something that you knew about. So it's our duty as clinicians, as, you know, health professions, to also educate those parents and give them all the information, being transparent with them that this is what you need, this is how you need to keep your child safe. So I think that's it. As Caroline says, she will circulate. If there's no other question, I can let you carry on with your training. Yeah, okay.
Thank you.
Well, I want to say thank you to everybody for coming on today's meeting. If you haven't already done so, can you please put your email address in the chat box so that I can send you the survey. Also information about PLOG, and also information about the forthcoming study day that PLOG is putting on the 5th of August. So those who haven't put their email addresses into the chat box, can you please do so now? And I will ensure that I will share this with you. This session has been recorded. I've done it as a webinar. So if you need to pass this on to any of your colleagues who may require this information, then I will also share the webinar with you as well. And thank you very much for taking part in today's study day.
Thanks, Caroline.
Thank you.
Thank you.
Take care.
Thank you.